So welcome here to a special session that I'm hosting here. Our guest, our international guest, Dr. Ronda, who is visiting us all the way from Italy, from the beautiful town of Genoa. And Marco is an expert in the field of advanced implant surgery and an expert in the field of tissue regeneration. He has come especially here to Los Angeles, to the gIDE Institute, to actually teach us and share with us his experience in GBR as a normal procedure for our patients, but with a next innovation, which actually is using a customized, prosthetically planned titanium mesh. So Marco, first of all, welcome to Los Angeles.
Thank you so much.
How do you like Los Angeles, California?
Oh my God. The time that I can spend here are only 2 days. And I don't have more time in order to enjoy relating this fantastic city. Next time, probably.
Okay. I know you live also in a beautiful part of the world, so you know I like to come and visit you. You come visit us. So tell us, you know, like you've seen GBR for many years. First of all, you've spoken and worked with many dentists around the world. What is maybe your number one problem and complication that you have seen that dentists encounter when they try to adapt guided bone regeneration for their patients? What is the number one problem?
But you know that the main problem is incorrect management of the soft tissues. And relating that you can have early exposure of the membrane, even if with a new product like the PTFE dents, the complication in case of exposure probably sometimes are limited, but in any case the main problem is the early exposure of the membrane.
Exposure, okay. So we know of course that exposure is a reality, unfortunately. I've been there, other colleagues have been there, and we have learned that like making and working with soft tissue, especially like releasing the flap, is an important step. Now I know that you have done a lot of research in this field.
Yes.
Again, thinking about our patients and thinking about our surgeons, where do you think that surgeons make the biggest mistake in releasing? Because everybody knows I need to do a release of the flap. Everybody knows I need to advance the flap. But where do they make the mistake? What is the mistake?
I could say that it's a long time that I performed the GBR. My mentor, you and Massimo Simion. We are speaking a time around 1992, 93. And I had big problems in GBR, I have to be honest. A lot of early exposure at the beginning of my career, and then I understood that the passivation of the flaps was the goal in the success of this procedure. At the beginning I applied a procedure that were proposed from the mentor like you, the periosseum incision, the full thickness detachment of the lingual flap, and then I tried to improve them in order to elevate coronally the flaps in a significant way in order to treat a big vertical bone defect or challenging case like in the anterior zone. And they introduced 2 different procedures published in 2011 and 2015, and with which probably I create a different approach to the passivation of the flap, respecting the integrity of the soft tissues, respecting the vascularization, and obtaining the ideal quantity of tissue that sometimes is needed for the bone regeneration.
Yeah. So I think some of us call this like the brush technique.
Yeah.
And I think like, you know, for most of us, like, you know, as long as we understand that this soft tissue management and the periosteal release has to be very carefully done. We have to protect the nerves, we have to protect the anatomy of blood vessels. But I think it's important for probably us to like realize that many people still need training with this. And it's like, maybe for you it's a natural, for me it's a natural.
Yeah.
But it's, I think, important for the viewer to know that it is something that can be done. And how many, if you think about like, you know, advancing a flap, what is an average advancement for you that, let's say, without going too challenging, just normal, an average, what's an average flap advancement that you can achieve in the maxilla?
It depends from the type of defect. I propose, in my opinion, an interesting formula relating the encumbrance volume, called encumbrance volume, with which you can define which is the quantity of tissues needed for the specific defect. That take in consideration the quantity of tissue needed not only for example, the vertical bone regeneration, but also in order to cover the new horizontality that is needed, in order to obtain the horizontal matrix sutures. We know that, for example, a correct horizontal matrix suture needed to play face to face 5 millimeters of tissue. It means 1 centimeter goes out. And so with this encumbrance volume formula, you can define which is the ideal quantity of tissue for the specific defect.
Good.
But normally in the upper jaw 25-30 millimeters
Is pretty normal.
yes, and in the lower jaw 4 centimeters, 40 millimeters, 45 millimeters.
That's good. That's big. So let's maybe move to like, so soft tissue is obviously still the issue, and now we go to bone. We have, of course, a lot of research with like titanium reinforced, PTFE, dense PTFE. I have heard, when we look, and I've read the research between titanium mesh and PTFE, that the exposure rate with titanium mesh is higher than PTFE.
Yes, probably with the old meshes that had a different texture, a different morphologies, with which the bigger holes and allows to the connective tissues in growth. But when the flap was seen with this non-regular surface of the meshes, probably it could cause a major exposure of the meshes.
So you feel in the new generation, so the micro-perforated custom titanium mesh, there's less exposure than the previous titanium mesh?
Yes, of course, it's sure, and I can compare the exposure of these devices in similar way to the PTFE dense.
Okay, great. So then, like, tell me, I'm of course like a GBR believer and user, and obviously I'm very interested in every new aspect. Why should I do all the hard work, you know, to prepare, to plan, and to do this titanium mesh if I have a good success with PTFE? What's the reason? What's a good indication?
Yes, the using of titanium meshes, we have already discussed it in the past, I remember, is indicated for more challenging cases. Because for the normal cases of vertical bone regeneration, I use normally the PTFE dents.
So like maybe one tooth, two teeth,
yes,
three teeth.
Yes,
moderate.
yes. But when the extension of the GBR is long, a lot of teeth, or in curvy area, or in complete upper jaw, or in very severe vertical bone region, the using of customized titanium mesh can help the surgeon and myself, of course, in the application of this procedure.
Okay.
In a short time, you have a already prepared custom that can be placed immediately there, and you have to concentrate yourself in the passivation of the flaps, in the suturing, and stop.
Okay. From a standpoint of bone quality, right? Like every regeneration has different bone qualities. When you compare the regeneration of, let's say, the smaller or moderate vertical defects versus these big ones that you're treating with a custom titanium mesh, is the quality different?
Honestly, I have to be honest, the quality in this challenging case is not good. I have to be honest, because the endosteal activity doesn't manage
the big distance.
Yes, the big distance. And the barrier limits the periosteal activity. But for this reason, after the removal of the barrier, non-absorbable titanium reinforced membrane or customized titanium meshes, placing the periosteum on the bone, the quality of bone changes completely. I harvested several carrots at the time of bone, regenerative bone, at the time of membrane or meshes removal, and 3 months later at the time of activation of the implant, and you can see that the quality of bone changes completely with the periosteum activity.
Yeah, I personally have had several patients where, like, you know, after vertical regeneration with just regular PTFE, also the bone quality was poor. And then I usually don't place implants at that time. I just remove the PTFE and then I close the flap, allow the periosteal activity.
Get a better maturation of
and
the
3-4
bone.
months later, you have basically dense
incredible.
bone.
Yes.
So I've seen that too.
This is biology.
Yeah. Is there anything else that you feel this titanium mesh, should we forget then completely about the old titanium mesh and we should just like only look in the new future, the micro perforated custom titanium mesh? Or is there a place for the older titanium mesh?
No, honestly, I had the possibility to compare the old titanium mesh with the new, and honestly, I believe that this new innovation is indicated in order to obtain a good quality of bone without any competition from the connective tissues, because with the old titanium meshes with the macro perforation that were isolated with the absorbable membrane, the time of barrier effect of the absorbable membrane was shorter than the time of bone regeneration. And with the macro geometry of the holes, part of the connective tissues grows. And so we had two different problems: the removal of the meshes, and then part of the missing bone below the membrane, below the meshes. Instead, in this way, we managed to isolate completely the connective tissue. The microperforation allows to have a minimal vascularization from the top, and in my opinion, this is the future.
Good. So can I, you think like, when I look at everything we are doing, so I feel that if we add your new research and all the people who work on this, I understand Massimo is also working with this, and we have done some cases together.
Yes.
So maybe we can divide now GBR into like 3 three treatment options. One is like, of course, small defects, resorbable collagen membranes.
Yes, I agree.
Two is like the smaller, moderate vertical and horizontal defects with titanium reinforced PTFE, like
yes,
cytoplast.
Agree, yes.
And then a third new dimension is maybe for the really long span, or curved or full arch.
Yes.
Where we now are possibly having a third option to treat patients.
Yes, I perfectly agree with your suggestion, your analysis. I use everything, but relating the type of defect.
Okay. Okay. Well, this is amazing. Of course, for us here in Los Angeles, it's a treat to have an expert like Dr. Marco Ronda in our center, and I'll give you the last word. So do you want to tell us something, some wisdom, a fun fact, give us something from your heart? What do you feel?
I'm very happy to come here for the third time. I received this prestigious invitation from you in your gIDE Institute. I'm very happy. I'm very happy also because it's a great opportunity to share our experience, right. Even if I am a second generation and you are the first generation, you and Massimo, first generation, second generation, even if I am 60. So no, thank you so much.
You don't look 60, you look like 47. Well, thank you so much, and thanks for looking and watching and listening, and congratulations to our colleague Dr. Marco Ronda from Italy for his incredible work. Thank you.
Thank you. Bye-bye.